The hypothalamic pituitary ovarian axis regulates ovulation and menstrual cycles via hormonal feedback loops. The hypothalamus secretes GnRH. The pituitary secretes the gonadotropins FSH, which stimulates ovarian follicle maturation, and LH, which surges to induce ovulation. Finally, the ovary secretes estrogen to regulate the uterine endometrium. Disruption of the HPO axis can lead to anovulation and abnormal uterine bleeding, most commonly polycystic ovary syndrome. PCOS is characterized by increased ovarian androgen production. Androgens are converted to estrogens by the enzyme aromatase in the ovary and peripheral adipose tissue, leading to persistently high estrogen levels. Due to negative feedback from estrogen, the abnormally elevated levels suppress pituitary gonadotropin release. There is greater suppression of FSH release compared to LH release, causing an abnormally elevated LH to FSH ratio. As a result, ovulation is inhibited by two mechanisms. Low FSH cannot stimulate follicle maturation, and the persistent LH to FSH ratio imbalance prevents the LH surge required for ovulation. The result is anovulatory infertility. Anovulatory infertility can be treated with ovulation induction agents that act at various levels of the HPO axis. Letrozole is an aromatase inhibitor that acts on the ovary to inhibit androgen to estrogen conversion. The resulting decrease in estrogen restores the normal hormonal feedback loop and increases hypothalamic GnRH and pituitary FSH release. Clomiphene acts on the hypothalamus. Clomiphene depletes hypothalamic estrogen receptors, leading the hypothalamus to perceive low estrogen levels. Without negative feedback from estrogen, the HPO axis increases GnRH and FSH release. Both agents restore the HPO axis, which results in ovulation.